Dr. Eunice Wang is the Chief of the Leukemia Service at Roswell Park Comprehensive Cancer Center. Dr. Wang's clinical research focuses on the development of early-stage clinical trials for acute leukemias and myeloproliferative disorders. She is currently the principal investigator on over 20 active clinical trials. Her translational research interests include the role of the marrow microenvironment in acute leukemia biology and targeted therapies. Dr. Wang has authored or co-authored over 90 peer-reviewed articles, multiple book chapters, and editorials. In addition to her research, Dr. Wang maintains an active clinical practice. Dr. Wang has kindly agreed to join us from an acute leukemia workshop in France today, so she will have to drop off after her presentation. If time permits, we will take a couple of questions after Dr. Wang's presentation before moving on to the next speakers. I'd like to say thank you very much, Dr. Wang, for taking the time out of your busy schedule to join us today and share your incredible knowledge with us. And with that, I will go ahead and turn it over to Dr. Wang to get us started with the first topic for today, which is MRD status.
All right. Thank you very much for the opportunity to speak today. I hope everyone can hear me. I will be discussing MRD status, or minimal residual disease, how it affects your chances of relapse in AML. As we know, AML is a devastating disease that occurs largely in older patients. It's a clinically aggressive cancer to have, and it's also incredibly biologically complex. As shown on the video, it can be characterized by many different mutations, cytogenetics, et cetera. So it's important to know specifically what type of subtype of leukemia you have in order to see whether your disease could be eligible for targeted as well as conventional chemotherapy approaches. In some patients, as we know, unfortunately, the disease can progress despite all efforts, and survival can be, in some individuals, very, very short. Now, what is the pathway to a cure in acute myeloid leukemia? And how does detection of minimal or measurable residual disease, known as MRD, help us in planning our treatment paradigm as well as achieving a cure? So I'm going to start out with what is known about the status of MRD, and I'm going to use as an example the treatment regimen for which we have the most data on the role of MRD and how it can predict for relapse. So this is a regimen where younger, fitter patients who have a diagnosis of newly diagnosed acute myeloid leukemia may be treated. This conventional intensive chemotherapy regimen has been utilized since the 1970s and generally is divided into 3 stages. After diagnosis, patients are given intensive chemotherapy with a 7+3 based regimen or some sort of mix of these types of drugs that are included in conventional 7+3, including cytarabine and an anthracycline class of drugs. Patients who achieve CR, which is approximately anywhere from 30 to 60 or 70% of patients, will achieve a complete remission, meaning there is no measurable evidence, by morphology at least, of AML on the bone marrow that is repeated, and that generally, per our pathologist, means less than 5% blast. Patients who achieve a complete remission, less than 5% blast, no evidence of clinical leukemia, and have recovery of their blood counts are then potentially offered what we call consolidation or post-remission therapy. And this generally involves, again, lower doses of the same drugs used in the 7+3 regimen or high dose of one drug, the cytarabine compound. Patients then continue, hopefully, to maintain this complete remission status, and then patients are transitioned to either maintenance chemotherapy approaches or possibly a stem cell transplant. What is MRD, or minimal residual disease? This is residual disease that's not detected by morphology. So in the presence of less than 5% blast, we think that we don't see any disease. But when you look at a deeper level, you can see that when we look under 1% or 2%, there's different degrees of residual disease that can be detected by more sensitive mechanisms. And you can see that if there is even a few cells remaining after achievement of a CR, this is going to lead to disease recurrence. And the depth of the response, or the amount of negative disease burden one can obtain, can be directly correlated with eventual relapse or the timing of eventual relapse. Now, acute myeloid leukemia, as I mentioned previously, is an incredibly biologically heterogeneous disease. So we know that it is characterized by many different mutations and cytogenetic abnormalities. Currently, there are two methods in which to detect MRD. One is using mutation-specific information, looking at real-time PCR for specific genes that are mutated and specific in the cancer. The other is to look for markers, proteins expressed on the surface of the leukemic cells, and testing for these markers with a variety of antibodies. There are different approaches, and they have different advantages and disadvantages. The real-time PCR approach is specific for the mutation and uses techniques like qPCR or even digital PCR that allow us to detect maybe 1 in 100,000 cells. So this ability to detect very low levels of disease is enhanced with molecular testing. However, multi-parameter flow cytometry is more immediately available. In our facility here, we do this in our institute. So there is a quick turnaround time, generally within a few days, as opposed to 5 to 7 days or even longer for real-time PCR. There now is techniques called next-gen sequencing, where not just one mutation can be detected, but multiple mutations found in that cancer cell can be analyzed in a single patient sample. And this, however, requires what we call bioinformatic analysis, somebody that can take the list of genes that are potentially mutated and make sense of them so that there's a clinical significance. What is the clinical significance overall of having MRD methods? Well, you can see here that in this review of 81 different publications published on MRD and AML, that overall, if you are MRD negative, your overall survival is much improved by about almost 20 or 25, 30% over patients who have MRD positivity. All of these patients were in morphological or pathological CR, but you can see a vast difference in outcome overall, as well as leukemia-free survival with this method. What is better? Is it MRD by some molecular method or by flow cytometry? And you can see really any detection of MRD by either of these is statistically significant in these publications. So it doesn't seem to matter which technique you use to detect this. However, if you have the ability at your institute and your practice to both molecular testing as well as flow cytometry testing, the ability to find the disease and to prognosticate is improved. And this is a study showing that you can detect different types of MRD by either of these methods, and detection or use of both of these methods enhances the ability to detect and to make predictions on this. When should we test for MRD? You can see here that at any time after you achieve a complete remission, it is important to retest. And the ability and the prognostication of MRD testing improves with serial samples. You may detect something at the first time you achieve a remission. It may disappear over time, in which case your prognosis will be better. You can see these mutations or detection of disease burden increase over time or remain undetectable. And each of these serial time points can give you a snapshot in what is happening in these patients over their treatment course. What about what time point is most important? We don't actually know, but all of them seem to be prognostic. This is testing for an NPM1 mutation after induction chemotherapy. Again, very, very good at predicting. Here are samples collected during that consolidation chemotherapy and after completion. And again, these are highly predictive. And we can even detect these mutations and MRD in samples before we proceed to an allogeneic stem cell transplantation. Now, in this data, Chris Horrigan and colleagues looked at samples collected from hundreds of patients before they went to transplant, when they appeared to have an optimally controlled disease status. And they asked which genes or which mutations are useful in predicting for this disease process. So here are the genes they looked at: FLT3, IDH1, IDH2, NPM1, and KIT mutation. they found that the detection of residual, for example, NPM1 gene mutation was highly significantly prognostic. You can see here, MRD, NPM1 positive, overall survival is much improved. Again, that same trend over NPM1 positive, and this correlates with relapse recurrence as well as relapse-free survival. Same thing was found for FLT3 ITD mutations, again, a significant difference, but patients who had mutations in the IDH1 and the IDH2 genes, really there was no difference in their overall survival. So though they were able to, with various very sensitive methods that they used to detect these specific mutations, they did not seem to predict for these. And these seem to be at baseline in this patient's potentially due to a process called clonal hematopoiesis. And so this is not a useful gene to measure. What about now you're going to say, well, maybe I'm getting treated with not with an intensive regimen, but many of our patients are now receiving lower dose therapies, including a venetoclax azacitidine or venetoclax decitabine. Does MRD predict for outcomes in these patients? And the answer is yes. You can see here that in patients treated with venetoclax azacitidine, that sequential, particularly over the course of 7 or even longer cycles, was predictive of differences in overall survival. These are a little bit skewed because patients who achieved remission and remained in remission continue to have testing, whereas those that didn't. But this suggests that this is going to be important not only for intensive chemotherapy, but other therapeutic approaches. Can we do anything about MRD? Well, there's some agents that we are now exploring. There is a low-dose oral azacitidine compound, and in early studies, using this compound as maintenance therapy after achievement of a complete remission, again, can be a marker not only of residual disease burden, but of response. So a certain percentage of patients who were MRD positive treated with this oral azacitidine had the MRD disease disappear with continued oral AZA treatment. We also know that when taking patients to transplant, if you can detect MRD positive or MRD negativity, the transplanters may alter the conditioning regimen to better address how to get rid of or control this residual disease through the transplant process. So in summary, I've shown data that measurement of MRD is very prognostic, and we think that MRD in the future has the potential to potentially replace morphological CR as the main criteria or determinant of response to any AML therapy, since it so clearly predicts for survival, relapse, and even transplant outcome. Importantly, these methods currently do not tell us anything about the biology of the residual disease. And many of these assays are not used in the community practice because they're not standardized now. However, in the future, we do think that incorporation of this MRD will be a new prognostic factor that we need to consider for treatment of our AML patients. There are guidelines which have been published and disseminated in the European Union telling us which genes and at what time points we need to be measuring MRD in patients. And you can see that most of these endpoints are multiple: diagnosis after 2 cycles of therapy and at the end of treatment. And these guidelines also tell us at what point and at what level the current data suggests that the disease is going to relapse. And so moving forward, we're going to be relying more and more upon these methods to help fine-tune our treatment for our patients to get the best outcome. So at this point, I'd like to stop and thank you very much for your attention. I greatly appreciate the opportunity to speak today, and I think I do have time for 1 or 2 questions before I sign off. Thank you very much.
Thank you, Dr. Wang, so much for that presentation and all that information. I know that was a lot of information. I do have one question that came up. I'd like to know, are all clinics across the US routinely using MRD testing in their treatment strategies? If not, should that be something that someone is looking for in, when looking for a specialist? Should they be looking for someone that's using MRD testing in their?
Yeah, I think most So most of the data being generated with MRD is being tested in academic centers. And so one of the benefits of going to an academic or an AML specialist is that they're going to have the ability to measure these and potentially offer therapies or transplant or either escalate or de-escalate one's therapy based on the presence or absence of MRD. So I do advocate that that is a potential advantage. We have patients that are receiving standard of care therapy in the community who come back to us every few months whenever they need a marrow done so that we can perform MRD testing and better inform the local practitioner and the patient what might be an effective approach. I see one question here in the chat. What medications are used during stem cell transplant to reduce MRD? As I talked about, when you go to a stem cell transplant, you have conditioning regimens, which are used to wipe out the cells in the bone marrow and prepare the bone marrow for the stem cell infusions. There are what we call myeloablative approaches, which are more potent in eradicating almost every cell in the bone marrow, versus what we call reduced intensity conditioning. So some transplanters would change the conditioning regimen to offer more cytotoxic or more anti-leukemic efficacy with what we call a myeloablative regimen. And if patients are at high risk or MRD positive, then there are increasing numbers of studies that are instituting shortly after the transplant initiation of what we call low dose or maintenance chemotherapy to try to eradicate and prevent relapse disease in the post-transplant setting. And for patients who are MRD positive going into transplant, there may be a strong indication that that patient post-transplant is going to need some additional therapy. If another question, if MRD testing starts to rise, at what level should patients or practitioners start thinking that they might have a possible relapse? I think that's the benefit of serial testing. There may be somebody that's positive immediately after therapy, but with continued therapy, and as we saw with oral azacitidine, that level may trend down. However, I think if the level is rising, I do think that that may be a rationale to start asking whether a change in the therapy is indicated. For example, if I'm giving patients consolidation chemotherapy and giving them the same chemo, cycle 1, cycle 2, cycle 3, if the MRD is rising over the course of that therapy, then obviously giving more of the same therapy might not be the best approach. And I might need to think about enrollment in a clinical trial or other approaches, maybe considering a transplant or changing to a different mechanism of action of the therapy. Because at that point, I certainly seeing a rising level would bring concern that at some point with further, non-intervention or same intervention, you will then develop overt disease relapse, which is much more difficult to treat. The benefit of MRD testing is to try to treat and address the issue before it becomes out of control. So unfortunately, I'm going to have to run, but I have included my email address, and HealthTree AML has a list, as I saw, of AML specialists throughout the country, which should be consulted if you have further questions about this MRD testing and what that may do for your individual case of AML.
Thank you so much, Dr. Wang. Thank you so much for calling in. Have a great afternoon.
My pleasure. Thank you.
Bye-bye.